Well, good morning. It's 9:01, and I'd like to call the Health and Human Services Committee meeting to order. The first item on the agenda this morning is public comment. So if you wish to speak, please come to the podium, state your name, and you have 3 minutes to speak to the board. Would anyone like to make a public comment? Okay, seeing none, we will move on to the approval of the agenda. Is there a motion to approve the agenda?
So moved.
Is there a second? Any discussion? Seeing none, all those in favor of approving the agenda, please say aye.
Aye.
All opposed, say nay. The agenda is approved. So moving on to consent resolutions, we have one item under our consent resolutions, which is the approval of the proposed minutes from the November 19, 2024 Health and Human Services Committee meeting. Is there a motion to approve the consent resolution?
So moved.
Second.
It's been moved and seconded. Is there any discussion? All those in favor of approving the consent resolutions, please say aye.
Aye.
All opposed, say no. And the consent item is approved. So we have no action requests today on our agenda, so we will move to committee reports, beginning with Jennifer Brzezowski from Community Action Agency. Good morning.
Good morning. Morning. Okay, so a few updates from Community Action Agency or OCA. If you didn't see the Facebook post, thanks to Scott and the communications department, we chose our poster contest winner, which is an awesome art contest for Walk for Warmth. And it was Addison from Zeeland High School. So Addison was able to receive over $400 in prizes for that poster contest. And then that design will be featured on posters in the area and t-shirts for the event, which is very exciting for high school students. So we're very excited about that. So again, the event, I will repeat it over and over again till March. It is March 7th, 6 p.m., EV Construction in Holland. And again, that supports our utility assistance program, the funds raised during that event. So some monitoring reports. So we had our STAR rating, which is the risk assessment from the state. We received a 4.5 out of 5, so great overall. Some of the items that we could have been a little bit higher on were outside of our control. So we were pretty happy about the 4.5 rating there. I talked about a mobile home event that we did with the Grand Haven Board of Light and Power. And although we didn't have a large turnout, they've kindly reached out to us and they want to do another one. So we're excited that's going to be something that will be ongoing. Again, starting in Grand Haven area, but eventually we're going to branch out to the rest of the county so that we can physically meet our clients where they're at. Weatherization program, we are in the process of securing 2 more contractors for that program, which is great. We usually get a decent amount of applicants, but sometimes the lag time with contractors and all the jobs that they have to work through slows us down a little bit. So having 2 more contractors will be very helpful for that program. So we're looking forward to that. I said it before, but again, I just feel like I need to do an extra shout out to Scott in our communications department. He has been so helpful. He's very talented, very creative, and he's put a lot of our ideas to life in the videos that he's been doing for the county page, for our Facebook page. Anytime we can further that reach to the public is always a win. So we're incredibly thankful for him. Again, broken record on this one, volunteer opportunities, again, for our food programs. We do send it out to churches. We send it out to our community network. We had to make a change in December because of the weather. And when we did the event on a different day, it ends up being pretty much our team. We're a team of 8, so it's kind of tough for us. We end up doing a lot of the work, and although we're happy to do so, that means that we can't do our other work. So utility assistance, weatherization, some of those things are being neglected. So that it's always helpful to have volunteers. It's really easy to sign up. It's on our website under volunteer opportunities. The next one isn't until February, so plenty of time to plan ahead. And really simple, loading boxes into cars, or just stuffing bags with cheese in our newsletters. So really, really helpful. And we're really thankful for our volunteers that help us every other month. Lastly, I just want to highlight a couple of success stories because I think numbers and data are important, but I think it's also really nice to highlight just those individual stories. It turns the numbers into like identifying people, and it can kind of make that difference between what is sometimes considered a hand out to a hand up, because that's really what we're all about. We have a senior in our food program. She is a delight. I've been able to bring the food boxes directly to her on a number of occasions. She's very thankful. She's in her late 80s. Her family lives out of state. She's on a limited income, and that food is really the make or break for her. So she called us. She sends us thank you cards every other month. It's so kind. And she called us after our last distribution and said, thank you. You actually, you made my Thanksgiving, because otherwise she wouldn't have had food for Thanksgiving. So I think that's so important for our senior population, just to highlight how we're helping in that way. Then we actually had one of our board members who works for the maternal infant health program. And she visited a family of 9, so 7 kiddos in the house, parents who purchased a home, did the inspection. The inspector did not do a great job. So when she visited the home, the entire family was sleeping in the living room, the entire family of 9. There were plumbing leaks so severe they couldn't be in their rooms. There were electrical issues so dangerous that they couldn't be in their rooms. So we were able to come in with our weatherization deferral program and do some of the repairs leading up to weatherization, fixing the electrical, fixing the plumbing, and then tightening up the home with weatherization. And the next time the social worker went out to the home, everybody was back in their bedrooms. Everybody was safe, warm, happy, and healthy. So we're just really thankful that we have the funds to do that in our program. And we're just so thankful for our clients too, that are willing to trust us to go into their homes and bring them the food boxes and, go through all the tedious tasks of scheduling. And it could be a bit invasive to have people in your home. So we're very thankful for our contractors, our clients. So I just wanted to report a couple of those success stories. Any questions?
Questions?
Oh, thank you for sharing those stories.
Of course, happy to.
All right. Oh,
Gonna say something.
Mr. Needham.
Just perfect person to have you, Jennifer, in that, and just in with your stating about being conscientious about being in someone else's home.
Mhm.
I recognize that going in other homes in my past work, and I just really appreciate your personality with that. And I think that goes a long ways in how people are feeling comfortable in wanting you to come alongside of them in that moment.
Thanks, appreciate that. I will have to give a shout out to our weatherization inspectors too. They go into homes that maybe aren't in the most ideal conditions, whether it be somebody that has a difficult time getting around, so maybe it's not, the cleanest home. And they are non-judgmental, very kind, very caring, and they really just want to educate the clients on ways that they can make their situation better. So they're an amazing team to work with. They do a great job communicating with our contractors too, who do the same.
Thanks for coming today.
Yeah, thank you.
And congratulations on your 4.5 star rating too.
Thank you.
That's fantastic.
Yep. And I think your story just highlights, how important that work is and keeping families safe and together.
Absolutely.
So, because that definitely can escalate.
Sure.
So,
Appreciate that.
all right. Thank you.
Thank you.
So next up, we have Jason Schenkel from the Department of Veterans Affairs. Good morning.
Good morning. How are we doing?
Good. Good.
Good. Quick update from us today. From the IT side, our online emergent application is up and running now. We've gone through a few tests and then we did a few actual live applications and it's working extremely well. I'm excited about it too because there's some back-end reporting that we can get from that. So the next step is to get that up on the website. So it's kind of what we really like about it too is it gives the applicant an opportunity to upload supporting documentation, fill out most of the application before it comes to us, which will really make us a little more efficient. So we don't have to track down so much supporting documentation. We'll already have kind of a complete application. And then the workflow process allows us to go through an interview face-to-face before the application gets approved. So we're excited to have that up and get that going. Facilities, no real updates on facilities other than, we got the monies moved into the CIP with some project strings now. Last time I talked with facilities, we'll start looking at contractor bids for renovations, the RFP processes for that. Staff, we're conducting interviews this week for the 2 new roles. So the goal is to have the new hires identified before we go into Christmas. May have to do a second round. We'll see how that goes, but hopefully we can identify some folks early into next year if we need to. The Veterans Committee voted and approved an increase to our county burial allowance. The first thing is they approved to raise the asset limit from 40,000 to 70,000. That just kind of goes with the cost of living. The last time the state raised it was in 2004. So it's been over 20 years since it's really been looked at. So we increased the asset limit. And then they also voted to increase the allowance from $300 to $600. And then so we'll push those through the committees to get up in front of the board for final approval. And it's not going to change anything to our current FY25 budget. So the budget's available. We averaged about 28.5 burials a year over the last 4 years. So the current budget should be able to facilitate that increase. A little bit about first quarter, just some data. Medical transportation, up until today, we had 71 rides. We're down a little bit in first quarter. It's a natural trend of the holidays. Most folks are pushing their appointments out past the new year. The doctors and taking time off through the holidays. And so scheduling is a little chaotic. So we'll probably start to see those increase again going into second quarter. Plus, we have some of our folks that head south for the winter, so we'll see them back in the spring. Our VSO appointments, we had 169 appointments over the last 2.5 months. So we're staying pretty steady with veterans and families asking for assistance with federal claims. Emergent funds, we've had 5 approved cases for $2,322.28. Mainly utility bills, some rent payments. And then burials, we had 5 approved going into this month as well. So that puts us on about average, typically where we're at. So yeah, that's kind of it for me this morning.
Any questions?
No.
Commissioner Moss?
Good morning. Just curious, if you have about 169 VSO appointments in the last couple months, how many of the appointments are new people versus returning?
Yeah, so that's a great question. It's a little bit difficult for me to gauge that since most of those appointments go through our outside organization, VSOs. They're not reporting that back to me. However, the caveat on that, there's now some ability for me to pull some of that data and I can get back to Commissioner Moss with that. Within our Vetrospec, which is our state-provided software, they weren't using Ottawa County as the location. They were using VFW or American Legion, which didn't give me visibility of that. Talking with the regional directors, they've now instructed the VSOs to use Ottawa County as the location of services, which now allows me to go in and see some of that data. So it's really about whether or not they want to provide those reports to me or not.
Okay.
Yeah. I would tell you if you look at the 169, you could probably take about 25% of that and of being reoccurring appointments. But I tried to weed those out when I do the report. And I'm also not including in that 169 any of the VSO services that I'm providing either. So, and I typically, I've been averaging about 5 to 10 a month.
Okay. So, interesting. Thank you.
I think the last time you were here, perhaps you talked about an upcoming spouse support meeting. Did that happen?
It did happen. We had a low turnout. It was the Friday after we actually had the really bad winter weather, and we closed the county down on Thursday, and then it was that Friday. We did have one attend. But yeah, I think as we grow, so we kind of actually changed that up. Now that we actually have Ann, who's really dedicated to do that, part of our process change is when we do our burials come in, we reach out. We reach out for a couple of reasons. One, to determine if there's any federal assistance that goes above and beyond what we're doing at the county level. And then two, part of our kind of protocol now is to ask if they would like for Ann to reach out to them. So if they say yes, then I give that information to Ann, and she calls and does a one-on-one. And if they're interested, then she invites them to the support group. So we should actually see that grow as the year progresses. So
That's great. Great. Any other questions? All right, thank you.
okay, thank you.
Okay, next up, we have Dr. Brashears with Community Mental Health.
Get the sweater today, don't I? Good morning, everybody.
Morning.
You'll get a written copy of my narrative report later today to be added to the packet. So a couple things. One is last Friday, for the first time in probably 5 years, all of the CMH staff had an all-staff strategic planning and holiday get-together. We used grant funding and we held it at Hope College. And it was the first time that the majority of the staff actually met each other. Even though we work, in the community and definitely within James Street primarily and in Grand Haven and in Hudsonville, most folks didn't know each other. So it was a good time to get together, acknowledge some of the struggles that we're facing together, go over some strategic plan items, and then have a meal together. I got to tell you, it was quite nice to see the majority of folks actually come to it. We have about 170 employees, about 165 people showed up. So, it helps that you do it but it wasn't a Friday, so I was a little worried that we're going to get the Friday flu. But that was actually very touching to feel connected with the CMH department as a group sitting together, and kind of like I had each department get up and acknowledge each other, and it was quite nice. We had some board members attend as well, and then we had one community member who straggled in, but we let them stay. So that was a nice time. What I was highlighting, something that you'll see formally in writing coming up at the CMH board, and then when I do my presentation to county commissioners, the two platforms for our strategic plan moving forward. One is to keep community and community mental health by the use of grants, millage, general fund, that's state CMH general fund, not county general fund, to develop and augment programs that the Medicaid benefit doesn't cover. That platform is really to say that in Ottawa County, we're beyond a Medicaid health plan. Now, as you remember, Medicaid is about 90% of our budget. So we depend on these other funding sources to fill in the gaps for services, especially for like older adults in our senior reach program, things like that, that our Medicaid program isn't covering. The other foundational plank in our platform is with the Medicaid plan will be a center of excellence. So what does that mean? That we have to ensure that we're using evidence-based practices, that our productivity rates for our staff are where we want them. We want to make sure they're seeing people face-to-face as much as they can. And so we're in a deep dive right now looking at productivity standards and how we're interacting with the community to ensure that the folks that are in our programs are actually getting enough contact with us face-to-face. And we're using evidence-based practices. Currently, CMH uses 5 evidence-based practices that are mandated by the state. At another time, I'll go through with this committee what they are, because I think that this committee would love to know some of these evidence-based practices and why we choose them. And just to remind the committee that the public system, the public mental health system, is the only system that's required to use evidence-based practices. In the private sector, unless they choose to, they don't have to. So things like our assertive community treatment team, which is a team that goes to folks where they're at, they have the highest severity of mental illness and the highest level of non-compliance with treatment, is an evidence-based practice that we do. It goes to the folks wherever they are. And it's mandated. So your CMH department has a combination of trying to keep community in it, non-Medicaid programs, and trying to maintain excellence on the Medicaid side of the operations. And it was good to see the staff there, all at different roles and functions in those 2 platforms. And so we're going to be really focusing on center of excellence and maintaining community and community mental health. Most of the CMHs in the state have removed the name community mental health from their name. They're called like Health West or Centra. I don't know, it sounds like cough medicine to me, but other names that really don't emphasize a strong public community-based system. So it's my vision and the vision of the leadership at CMH with the CMH board to ensure that we always have community-based programs that are not dependent on Medicaid, and the millage helped us with that considerably, and to make sure we have enough Medicaid to cover the Medicaid health plan obligations. So I'd like to update you a little bit, last time I was here, on our projected budget deficit with Medicaid. As you became aware last time I met, at the end of the 4th quarter last fiscal year, which ended on 9/30, we discovered that we actually had a Medicaid deficit. That was due to a couple of factors, just to remind the public and the commissioners. It was due to a decrease in Medicaid revenue, an increase in utilization for things like residential services, community living supports, and autism that were unanticipated. And that's the major drivers of the deficit. We did have some planned increases for staff and some planned positions that at the time when we were developing the budget for this fiscal year, we believed we actually had a surplus in Medicaid. So we actually created a whole bunch of positions and upgrades. As of last month, I've put a freeze on those. And we actually have 14 positions that I have frozen that are either newly created positions or vacant positions. Because while we're still determining the cause of the Medicaid deficit and how to fix it, I have to stop the bleeding, so to speak, in terms of projected expenditures not matching revenue. So this group, I've sent it to some folks already, but this whole group will get a list of those positions and where they are that are frozen. Some of them are new positions, 6, some of them are not. We have a total of 14 of them. They're vacancies and we're holding suit. These are all positions that Medicaid is funding. I'm not freezing positions that a grant is paying or liquor tax might be paying or it's a millage position because services must continue. But I am being aware of the Medicaid deficit and working with the regional entity that controls our Medicaid funding to address the fact that I fundamentally believe that Ottawa County does not get enough Medicaid revenue to meet the contractual requirements of our Medicaid contract with them. And I'm in active dialogue with the region on how to address that issue and at the state, and we'll provide regular updates and opportunities for advocacy for county commissioners and the public to address what I call inequitable Medicaid funding. It shouldn't matter where you live. The Medicaid rate per person from the state to deliver those services should be identical through every CMH in the state because it's the same benefits, the same criteria, and the same service opportunities. Ottawa County residents are getting harmed because of how charitable we are in a lot of cases. That we do so much for our folks with extra stuff that over the years, we haven't relied on Medicaid in the way that I think we should have. And as a result, we've kept our Medicaid expenditures at bay by augmenting it with millage, general fund, other funding sources. I intend to not let that continue. I intend to understand the true cost of Medicaid services, let the region know what they are, and fund and fight to get the money we deserve so that we can maintain the community and community mental health with those other funding sources. If not, all I'm going to do is supplement Medicaid with other funding sources. This CEO is not going to allow that to happen. We're going to keep moving forward and solving this. So I've immediately put on a hiring freeze. I've also developed 4 new systems related to utilization management to help us deal with an increase in residential placements. Each residential placement that we get at CMH costs $100,000 a year. We had 20 of them that were unanticipated. Do the math. That's why the budget's over by $2 million. Just to remind the commissioners and the public, CMH does not get a dime more in any funding source when new people show up. So Commissioner Moss asked our previous guy, how many people were new folks? They're all new to us every year. We've seen a 200% increase in autism services. We've seen a 100% increase in people seeking services for the developmentally disabled, and we don't receive any more money to serve them. So as Medicaid stays flat and we have an increase in utilization, we have to keep cutting or finding ways to manage the budget, meaning decreasing services for some folks or expenditures somewhere else. It's my belief that that's not appropriate when you're running a Medicaid system, that there should be a way to gauge an increase in utilization with an increase in revenue. So I'm actively working with the state, the region, to look at ways to fix this problem, because it's only going to continue in our department. So that's it on the kind of the Medicaid update with that. I had the honor of completing my last of 5 educational series on the CMH funding sources. If people remember, I held them on Fridays. It was called Did You Know or Do You Know? And I went through the 5 major funding sources of CMH and our obligation attached to them. My next series will start in January. It will focus on access standards. What does the community need to know about how to get into CMH and what we can provide for you? And even though they're plastered everywhere, it can still be a mystery to folks. And so I'll be holding a 3-part series on how to access CMH services, the criteria we use to accept folks, and what do we do with folks, or where do we refer folks that are not actually eligible for our Medicaid services, but maybe for other programs that we have. And I think that what I'll do is when I report monthly to this group, I'll just attach the last presentation and you can look at it at your leisure and ask questions on it. So there's a continuous education stream about who we are, how we're funded. The County Commission should also know that the Lakeshore Regional Entity, that is the entity that controls our Medicaid dollars, which we're a member of that group, has not signed the contract with the state of Michigan to receive Medicaid services. Technically, we're without a contract right now, or actually under the terms of the old contract still. This is problematic because if we don't have a signed contract soon, the state could say, you're no longer eligible to be a Medicaid provider, and somebody else is going to have to manage it and provide the service. We're not going to let that happen at the region, but there are some contractual issues that are preventing the regional entity from signing a contract with the state. The biggest issue is how much should they have in their rainy day fund, which is called the Internal Service Fund. How much Medicaid should the region hold? It's in our interest that they hold a lot, enough to deal with, say, unanticipated increases in Medicaid expenditures, so that Ottawa can use that money to fill in the gap, and then eventually you have to pay it back over time. So the big argument is over how much of the Medicaid dollars should the region hold. The state says you should hold no more than 7% of the revenue that you get in this account. We did kind of like a study to an actuarial study, and it was recommended it's about 10.5 or 11% is needed for the region to have in abeyance just in case we need it. And so that's a big issue that's happening at the state level. There are 3 regions, because if you remember, there are 10 regions in the state. I know it's a very complicated, bureaucratic, many steps, take all the money all the way down system, right? But there are 3 of these regions that are actually suing the state of Michigan over the contract issue, because the state of Michigan has threatened to withhold funding, even though there's an existing contract still in place. So there's a lot happening at the state level that has a dramatic impact on us, and I'm staying on top of it the best I can, and I'll be giving regular updates to the CMH board and to this group. Lastly, since my arrival, I've engaged in what I would call the systems look, to look at our internal system. I'm about 5 months into it. And I've decided I need to increase my scope from, I was looking over the last year and how things are currently structured. I'm going to have to increase my systems look to cover the last 3 fiscal years. I'm going to tell you why I'm doing that. The first reason why I'm doing that is that over the years, we had a grant called CCBHC, right? It's a federal grant we got that turned into a demonstration project. We hired positions, as this commission knows, based on this grant funding. I need to ensure that the positions that were presented under CCBHC funding are still being funded by CCBHC funds. It's a different funding source we have. If not, I need to explain why that is and what the plan is. We had a CCBHC grant that went from $2 million a year to $1 million. I need to make sure what happened to those expenditures. Some of it had to be migrated to traditional Medicaid, which added to our deficit. I am going to ensure a systematic and comprehensive look at all of our funding sources for the last 3 years to get a big, better picture of what's going on with our budget, where our expenditures lie, and if we have to make difficult decisions, how to make them. Saying that, this is kind of a statement that, you know, when you think of our Medicaid deficit, you go, why is he saying this? I do not believe that we can cut Medicaid positions within the CMH department. It is my belief that the CMH department is understaffed in key components of Medicaid management positions and services to deliver the services in the way they were intended based on evidence-based practices and best practices, and we have gaping holes. Yes, I've put on a hiring freeze, but that's just to do freeze frame, stop, don't add to the deficit. Let's kind of look at what we're doing. But it's my belief that the Medicaid side of CMH is underdeveloped, underfunded, and has atrophied over the last 5 or 6 years based on flat Medicaid rates. So this is a delicate balancing act that I have to do right now, but I'm going to do it and keep people abreast of the results of it. This is not to blame past CMH administrations. They're just doing everything they can to keep the funding sources all in line and get to a 0 budget. But our Medicaid infrastructure, in my opinion, is not sufficient to deliver the services in a way that I believe they need to be done at the levels that they need to be done. So we have to develop a strategic plan. You can't have excellence when you have no space to provide the services. And we have a lack of space. I'm working with Cameron. We're kind of working on a plan. We don't have enough physical space for the employees that we have. I got people still in closets, for crying out loud, right? We can do better as a county. So you can't have a center of excellence with not enough folks in Medicaid, not enough space to deliver the service, not enough revenue to do it. It's going to take 24 months to turn this around, but we will do it. So I covered a lot in my update today, which I have in written form, which you will get, and I'll entertain any questions that you may have.
All right, do we have any questions? Mr. Moss.
Sure, just briefly, yeah. Good morning.
Morning.
And thank you for the look back and really digging into the details and, you know, getting good perspective by going back a few years. I think that's great. just for my clarity, Medicaid funding is federal funding technically, right?
It's not. It's
It's
actually, well, it is. It comes from the federal government on a waiver program to the state.
Okay.
And it meets the state's obligation to meet its mental health code. So it can seem like it's not, so CMH is not a federal program. The state just happens to use Medicaid as a methodology to pay for its state system.
Okay.
If the state chose to, it wouldn't have to have waivers with Medicaid at all. It could just have a basic Medicaid mental health program. And that's what's confusing. It's not, so our CMH department's not, or Medicaid's not a federally driven system. It's a state-driven system using federal dollars in a match agreement to pay for it.
Okay. All right, thank you. I think you had mentioned a couple weeks ago that the state budget, they had removed some funding.
Yeah.
Was there any updates on that or any change, or is
There's no change, but we have a board association, the Community Mental Health Board Association, who's been to our CMH board meeting and is coming again in January. And they're fighting for the release of additional dollars that were budgeted. The whole system, according to them, and I'll send, if people are interested, the studies from them show how underfunded the system is. Because it's probably a $500 million problem statewide.
That's kind of what I was wondering.
Yeah.
Yeah. And so in that case, does the state have to work with the federal government?
Yes.
Or the state would have to potentially come up with additional funds on its own?
Both.
Both.
And the state would have to find a methodology that treats all CMH regions equally. And until they do that, you're going to have the haves or have not. There are some regions in the state that have a $10 million surplus. That ain't right. So I'd like to be that region, by the way.
Yeah.
But the point is that, okay, that money needs to be moved around in an actuarially sound way based on encounter data, how much encounters you're doing. There should be movement within the system every quarter
Right.
on this, and there isn't.
Is that money at the LRE level?
Yes.
Interesting. Another random question,
Oh, yeah.
just my last one. Is it possible to have 50 or 100 new residential placements pop
Yes.
up in a year?
We are projecting over the next 3 years, we have at least 50 people that need to be placed in specialized residential. The reason for that, Commissioner Moss, is that the other systems in the county have fallen apart. There is no affordable housing for anybody, especially folks with developmental disabilities, autism, severe mental health. And the level of care called general AFCs, like a general board and room and board thing, they are collapsing. And no new ones in Ottawa County are developing. And so the only thing that's left for people that need residential services is specialized residential care. And that's what we've experienced the last 2 years, is an increase in that.
The specialized residential care, you have to have a residence, right? But do you also have to have caretakers?
Yeah, so what a specialized residential program is, it's actually a group home. So it's run by an organization with paid staff there. It's not the person's actual residence. And so for specialized residential, it means that the person has a level of need that requires staff observation and intervention, usually in a shift model for a second or third shift. And, like Benjamin's Hope is an example of that in this county. Harbor House Ministries and Janison is an example of that in this county, MOCA. And so that's the service. And the cost of care to provide those services have gone up tremendously because the cost of a direct care worker has gone up 200% in the last 5 years. But the rates haven't.
Is the staff available in the county?
Very difficult to find staff in Ottawa County because we are blessed with other occupational opportunities, especially factory work in Holland. We are competing with factories that can pay 20 to 22 bucks an hour. The average wage for a direct care worker in these homes 5 years ago was like $9 an hour. Now it's 17. And that can't even attract the people. Because this is difficult work. This is dealing with people with significant challenges. Lovely people, love them, but it's challenging. So in Ottawa County, we have a unique problem of having other opportunities, which I think is a good thing for employment. But in this issue, it's hard for them to find staff. The turnover rate's quite high.
Thank you.
You're welcome.
Mr. Cosby.
Yes, and so you were talking about utilization increases in Ottawa County. That's probably not happening in a vacuum, correct?
Correct,
Yes.
statewide.
Statewide. And do you, in your peer group, in the board association, discuss kind of those concerns, especially as we talk about aging out of autism as an example, but there are other reasons why.
Yes, the biggest growth in the state is autism services. To meet criteria for autism services, you only need to endorse 2 items on a scale called the ADOS at any level. And so it's actually easy to meet eligibility. Determining what you get is the challenge. The other thing that's impacting the autism is that there's a bill, not a bill, there's from the state, they're actually going to mandate that we pay ABA providers, those that do applied behavior analysis or even their aides, $60 an hour without any increase in revenue. So that's a 250% increase in some of these rates. So we're getting unfunded mandate increases for salary wages to attract professionals to do autism services. Sometimes we have people that get 40 to 60 hours of ABA treatment a week. So yes, we meet as a group. There's a lot of hand wringing. I'm into more solutions, like, having actual ways to deal with this issue. That's why the funding equity movement is going to be important. It's also understanding on having utilization limits on the amount, scope, and duration of services. We should offer a base package. And then if someone needs more than that, because it's medically necessary, give it to them. We shouldn't have a situation where people are saying, well, I could use 40 hours and we give them 40 hours. So we have to change some of our philosophy in how we've been authorizing our services for packages, not to restrict services, because if it's medically necessary, we shall provide it. And that's the thing people have to understand. We have to provide the amount of services that's medically necessary as mandated in the mental health code and the provider manual, regardless of how much revenue we get.
Well, and when you're projecting 50 potential, people needing
$5 million.
Exactly, and we are budgeting for 12 and increasing a
Yes.
3% rate. We're not going to, so.
We're not even close. Our current budgeting practices we've had in the county is just to increase the departmental budget by 3%. Our rate of growth and expenditures are far more than that. So we have to get an accurate forecasting model, which we're working diligently on with fiscal services right now.
And you thought maybe your new software? to
Yes.
EMR
Oh, that's
might be
true.
helpful? Yeah.
That's a good update. We are installing by June our new electronic medical record. We came up with the name. There was a huge contest. It's called Auto.
Ottawa?
So Auto will be our new system that help us with utilization management, our electronic medical record needs. Believe it or not, no one in our department fully understands the current system we have because we had such a turnover in staff that there are very few people that understand in an intricate way our current system. So one of the things I wanted to do was to put in a new system that the state uses, every other CMH uses, to develop a common language within our department on how we're approaching these things. And what's happening is usually it's stressful to do one of these things. This is actually bringing staff together. They're like, wow, I could have had a V8 that can do that. Now we all know, right? And so something that usually is a heavy lift in putting in a new electronic medical record system and UM system is actually a unifying force within CMH right now, because we're all learning something together with manuals so that in the future, if we lose people, it's right there. So yeah, thanks for bringing that up. I forgot about that. That's a major thing that we're doing to stabilize things.
Thank you.
Any other questions? All right. Thank you so much.
Thank you.
All right. Next up, we have Adeline Hambley with the Department of Public Health. Good morning. Good morning.
Thought you'd want that. Good morning. A couple of updates. Just yesterday, we were notified of a poultry farm that had highly pathic avian influenza. So we don't really have any details on that yet. other than what I believe MDARD put out in the press release. So hopefully we'll get some more information this week. We do have a new respiratory illness report that was posted online 12/12 on the webpage for data and statistics. We are seeing flu and RSV increasing, not outside the parameters what we usually would expect to see this time of year. But, you know, for healthy holidays, as usual, stay home if you're sick. Wash your hands. And then I have to put a little food safety plug because everybody brings like their own things kind of. So to make sure that you're cooking it hot. If you defrost it, to do it in your fridge, not on your counter. And, you know, don't let your aunts or grandparents leave the leftovers on the table for hours and hours. Like wrap it up, put it in the fridge right away so that nobody gets ill the next day. So also we did have receive additional funding for the hearing and vision program. So the state allocated some additional funds for that program. We were allocated 125,000. We will be able to accept it when eGrams opens. eGrams is the state system for accepting the funds they give us here in January. So once we accept that funds will be coming back for the board to ask for a hearing and vision tech position to be approved. But we need to kind of wait till the funding is open and accept it before we bring that request to you. At that time, I'll have somebody come from hearing and vision program too that can provide additional information and details about the program. And then as was discussed last time, was the kindergarten oral health assessment, and you requested more information. So Casey Helsinga is our dental health supervisor. So she's going to provide a bit more information and answer your questions for the kindergarten oral health assessment.
Great, welcome.
Hello, thank you. So you all got that information that I sent? I made that up on the fly, so. There's a lot of variables with this program. So as I mentioned, the goals for the state. So big thing, it's a state-led program, so they make the decisions and we kind of just provide it in the county for them. The only decision I made, I can't remember if I put that in here, is I will not start screenings until March 1st, but I can get into that in just a minute. So kindergarten oral health is to provide a dental screening for first-time kindergarten students or first-time first grade students. So if someone moved from another state and they were not a kindergarten student here, we would then provide a screening for them. And a screening is very quick. It's done by a dental hygienist through the local health departments, and it's very fast. They typically have 20 teeth. Some of them have their 6-year molars, so 24 teeth, but typically 20 teeth, and we're just counting and looking. And obviously there's no x-rays. It's just to give us a general idea of how their oral health might be, not to say that they are cavity free without the x-rays. Again, they take about 60 seconds. If they have no restorations like fillings or crowns on their teeth, it's very quick. Or if they have no decay. So if they have a clean bill of health, it's just really fast counting their teeth, telling them that they have 20 teeth. And then depending on how the clinic is run, a little bit of oral health education. I mean, they're mostly 5- and 6-year-olds, so I don't know how much they'll retain. So really kind of make it fun and introduce brushing to them morning and night, that kind of stuff. And then anybody who, so again, we can't legally diagnose as hygienists, but we can provide suspicious areas. As you know, we kind of know, but so what we do is every parent gets a parent note that I made up, and it provides some oral health education on there, and then it provides just like their next steps of what they need to do to follow through, that they need to see a dentist for regular routine care, which is what we recommend, or if they need to see a dentist for just general treatment possible treatment needs, or urgent, meaning they have abscesses or they have rampant decay, which means they have multiple teeth with cavities on them or large cavities, or the child is in pain. So the goal is really just to increase oral health awareness. And we are trying to eventually get everybody into a dental home, which is hard because there's a dental shortage right now. So it's hard. But I feel like it's a really good introduction for parents to understand that the earlier that we work on oral health, better the long term will be, and we can be proactive instead of reactive with cavities and things like that. So yeah, we're just trying to improve the overall oral health for Michigan children, ensure that children stay in schools, and raise awareness about the importance of it. The more that you do now, like I just said, the less you have to do later. Kids cannot be excluded from school without this requirement. I actually run clinics in the schools, so I can offer it to schools that, hey, I can come in. Parents will be notified that the health department is coming, and they have the option to opt out. So if they have a private dentist, they can have their dentist fill out the Michigan, it's a 6067 form, it's called. They can have their dentist fill it out. We're just kind of there to kind of help the vulnerable kids, the ones who can't get to the dentist or haven't gotten into the dentist for various reasons. And believe it or not, I've even screened other dental hygienist children because they're like, I don't want to take my child to the dentist to get this form filled out, just do it for me. So it's kind of a convenience thing too. And then, like I said, it's very, very fast. And I think it's a good introduction because I have a mask and glasses, in gloves and a lab coat. So it's kind of like the scary situation where you're seeing this person coming at you, but they're in a chair, they're sitting. I'm usually standing. I might squat down if I can see everything. I just use a disposable mirror with a flashlight, and it's really quick. I explain everything that I'm doing. I show them their face, usually in the mirror, show them the flashlight. And it's a good introduction before they have to get in the big chair, the room that's a little bit more intimidating. So yeah, we ran in-school clinics, kindergarten roundups, summer clinics at the 3 locations of the health departments or the county buildings. And then honestly, parents will call me, and if I'm there, I'm like, just come in and I'll go ahead and count the kids' teeth really quick if I'm there and I can make it work, or they'll call ahead and make an appointment. It's just one screening I might do a day if they call. So I'm just kind of there to help the parents and guide them or really what they need to do to keep their kids' teeth healthy. So we can start screening kids in the spring before their kindergarten year, like I had mentioned, but it can't be earlier than 6 months before their first day of school. So because we have so many different districts and start times, I just said March 1st is when the health department will start providing screenings. But if they get a screening done in February by their dentist, that's fine. I'm not going to be a stickler. So yeah, that's pretty much the gist of it. We're just trying to get in the schools, and I have a clinic coming up here. I think it was supposed to be last week, but there was a snow day. So we're going in January, and my IT, Kim Moore, I have to give a shout out to her. She's kind of streamlined the process for us because there's so much paperwork with this program. And then we put the children's information into our dental software, and then we put it into the state's portal. And then I also have a spreadsheet. So there's kind of a lot. So she actually helped where we can just kind of enter everything in, and it auto-populates into the 6067 form for us because the paperwork in the school writing it takes so long. So then we have a little printer that we're going to bring with us. We can print the 6067 form. It's got some stuff already up in there, like my signature, my name, things like that. And then we can add the date, the child's name, the day of, print it and put it in an envelope. And that goes home with the child along with a parent note specialized for them about what we found and what we recommend. So that's a big help for us. But there's a lot of paperwork, administrative stuff behind the scenes with this program. I think it's great. I think it's going to be good. It's still in its early stages, so there's a lot of kinks to work out. But I think it will be a really good thing. And I'm starting to work with local dentists, hopefully going forward too, just to try to get these kids a home instead of just, hey, here's what you have going on, but there's nowhere for you to go. So, yeah. Any questions? And it was kind of a lot.
Thank Mr. Miedema.
Thank you for being here today and for the information that you had given to Adeline to pass along to us. That was very informative, and I appreciate that. Obviously, oral health is really important for overall health, and so I applaud anytime that we can get behind helping students with our oral health. I do have just a couple questions as it relates to just thinking through the parent's perspective and maybe questions they might have that I still haven't heard. Do you know like how it actually looks like when classes are maybe coming to get a quick 60-second screener? Are they all coming down to a room together? Like, can you kind of walk through that a little bit? Because when you go to a dentist, most parents are going into the room with their child. And I think that would be just a question that most parents would have in the school setting.
So, no, we do not. I do not take 20 plus kindergartners at one time. I learned my lesson very early on. I've been working with second graders where you could take 5 second graders at a time. You cannot take 5 5-year-olds at one time while you're trying to count and maintain those 4. So I'll take like 2 or 3, and it depends if I'm by myself or if I have help. So, yeah, we just pull them from class and they come right down. And the parents don't opt out, so they kind of know that they're not going to be present for the treatment or for the screening. I'm not doing any treatment. So yeah, they have the option to opt out if they don't want their child to be screened without them being present, or they have the option to even come in if they wanted to. Which kind of would defeat the purpose of just trying to be in help for the parents, is eliminating an extra step for them. But they're more than welcome to come. There's no limits on parents being present. Even for when they bring them into the health department or we do the kindergarten roundups, parents are there. So.
I guess the next question, so if you have a couple of the students in there together, how are you handling the confidentiality with one child? Let's just say that you found some concerns. Do you share those concerns with that child, or how is that handled?
Not really because of their age. So when they're in a group setting, I'm recording everything or having someone record for me, so it's all on paper. I might just ask a simple question. Do you have any, does it hurt when you eat or anything like that? Otherwise, I'm just doing generalized oral health education with them. Like, so if there's a group of 5, there's one clinic we ran, it was exceptionally ran. They brought in 5 kids at a time, 4 sat in a chair, 1 got screened, but the kids are far enough away, they can't see anything or really, they're not paying attention to us. And then at the end, I grouped up and then did their oral health education like that. So
Okay.
it's as private as it can be, but nothing is verbalized in the sense of, hey, you have 17 cavities or anything like that. It's very.
Is it up to each school to decide how long, for example, if someone wants to opt their child out, is it up to the school to determine what that time frame is? Let's say that they sent a letter home on a Tuesday. Is it up to each school to determine the communication factor, like when they actually need to turn that form back in?
Pretty much. So there's not necessarily a form. It's up to the schools to relay the information to parents. And then parents are supposed to send a signed documentation. Sometimes parents just verbalize that they don't want their child in it. And the school they'll provide me a list of the students in each class. And then I have them cross out any child who opts out. So there's no, I think it's best if I provide the school with a date, and then the school can relay that information to parents saying, hey, the health department's coming January 13th to do dental screenings if we don't hear from you, or whatever information, however they might share it with them, just to let them know if we don't hear from them, we will see their child.
Okay. And then how is the communication sent home? Is it sent home with the child? Is it mailed home?
The information that I find in the screenings.
Mhm.
So it is in a sealed envelope with just their first name and their first initial, their last name. And then I actually typically will walk them to class and have them put it right in their school bag.
Okay. All right. Thank you.
Any other questions?
Oh, you did fine.
I could talk about this all day.
Just trying to think through the parent perspective, right? Of, I think most parents would greatly support oral health. I think it's just some of the privacy as well as the confidentiality, as well as even thinking through, like most parents, like I said, come into the room with them in a room. And so I think it's just thinking through some of those, they're young. And so this isn't like a middle schooler, high schooler. And so I would anticipate that would just be potentially, I used to teach preschool.
Right.
So coming from that mindset of, I think there's some parents that would be totally fine. And I think there could be other ones that just have some concerns about their child being left alone with a stranger they don't know. And so that was why some of my
Right, yep.
my
no, that's a very
questions.
Good question. And I'm kind of in a unique situation in our county because I've been in oral health in our county for 12 years. So many of the schools I have a great relationship with, so they do know me. I know the parents don't, but they can kind of provide that comfort in saying, hey, we've worked with this girl for 12 years. She's great. And sometimes the teachers will stay in the classroom with the kids. Sometimes the teacher is present. We had another clinic we ran and the teacher brought all of her whole kindergarten class down, and she managed them way better than I could. And she just had one in the room and the rest were out in the hallway, and she managed them out there. and then and it was just a little bit more private in that sense.
Yep.
So it's really how the school chooses to run it. I tell them, I kind of guide them and tell them what my expectations are in a sense, but I will accommodate whatever they would.
Okay. Appreciate your information.
How many kindergartners are you anticipating doing assessments on?
So there are 4,000 kindergartners in Ottawa County. I asked the state what her goal was, and she told me all 4,000, which
Wow.
it's most likely not going to happen. So I say if we can get 1,500 to 2,000, I'm good with that. I mean, I obviously I want everybody to have oral health care, and that's the whole goal of the program. So I feel like I'm very influential, and I want them to meet me and then me to encourage them to get, and I don't run all the clinics, but I do coordinate a lot of stuff. But yeah, so if we can see half of them, I'd be good with that. But the goal is statewide, even though they opt out with the health department, they still have to get a dental screening with a dentist, which is kind of a challenge in itself right now. I think Addie had mentioned last time she was here that we ran into some problems with some districts where they were confused. They weren't letting the children start school because they didn't have the dental screening. So then I was getting parents calling me and saying, I scheduled a dentist appointment in June, but the first time they could get me in for this was December. So that's kind of where we're at. It's not uncommon right now to call a dentist and have an 8 or 9 month wait to get in as a new patient. So that's been kind of hard. And yeah, but hopefully we can help kind of ease the flow for the dentist, because I feel like if they had 4,000 parents calling them saying, hey, I need a screening before school starts, kind of a lot. Even for me, it's a lot. So
Yeah, it is.
yeah.
So I have one other question too, in regards to, you said that you were entering the data
Mhm.
and then that goes on to the state.
Mhm.
And so that particular part is something that sometimes parents, you know, in regards to other issues, haven't wanted their child's data,
Mhm.
being sent to the state or whatever.
Mhm.
Is there any opt-out on that portion of it, or is that pretty automatic?
So I actually had said to the state at one point that we just didn't have time to do it. And they sent me a thing saying that it's required to input the data into. I feel like that's still new too.
Yeah.
I don't know if that will be a forever thing, because they really care about the numbers of
Mhm.
how many we screen, how many are referred for routine care, urgent care, or just dental treatment in general. But for now, it is a requirement for me to put that in the portal.
Okay.
And I don't know who sees the portal. Like, I can't even run a report of like the children's names. I can just run a report of the number of kids that I screened on this day.
Do you happen to know, so then when kids are going to their own dentist,
Mhm.
are dentists also required to enter that for the state?
No, that was a thing that came up, and I was like, no, don't have dentists do that. They don't want to.
No. No.
So parents still bring the 6067 form, which is the form that we have to fill out for every child. So parents will bring that to the dentist, and the dentist will fill that out, and then parents will turn that into the school. We do not turn the 60, I left this part out. We do not turn the 6067 form into the school due to HIPAA, because
Okay.
it does provide a little bit more specific information. Just regarding, it's kind of just a yes and no that they have to get decay. There's no specifics on it. I actually made my own separate form with tooth numbers on it. So if I ever have to talk to a parent, which I do, I can refer back to it and say, hey, there's 7 teeth that I'm concerned about, but that's never on the 6067 form. So that's very, very private.
Okay.
But we don't give the 6067. All the school needs to know is, yes, they had a screening. And the schools actually have to enter it into MICR for all.
Yep.
So they just have to mark the box. It's another step for the secretaries, which I also tried to veto, but I didn't win on that one either.
Yep. Okay. All right.
Yeah.
Thank you.
Awesome.
Any other questions? Nope. All right. Thank you.
Thank you. I had one thing to wrap up, kind of aligned, that Casey didn't mention, and I think has been a theme, is that there is a real problem, difficulties hiring medical professionals. So the dental hygienists and dental assistants. Right now, we have 2 dental hygienist positions posted on our website. We're trying to recruit for, get some people, because at this point, Casey's a department of 1. She doesn't have any dental hygienists, so all 4,000 kids, and then the miles and we have a dental assistant program. There's been some frustration with that. I have met with Mr. Wetmore numerous times, I think in person, starting the 1st of November. I emailed follow-ups on 11/4, 11/7, 11/11, 11/12. On that first meeting, I was given a verbal okay to post the position of a dental assistant. I have not gotten any response. I spoke to him at the last Health and Human Services and got a verbal okay, which I summarized in the email I sent to this committee. Again, haven't gotten any confirmation on that email, sent an email follow-up on December 3. So here we are, over a month out for programs that have no staff. And I can't get a response to get that position posted. So I think that's important for this committee to know. Just because we're going to have metrics that we're going to have problems meeting. Again, because Casey can only do so much, so. Yeah, that is it. And we have any questions on the information I provided?
All right. I think we're good. Thank you.
Thank you.
Okay, and then next up, we have Kendra Spanger with the Department of Health and Human Services. Good morning.
Morning. Just a couple of updates. First, on our assistance payment side, we did get moved our universal caseload, which means that cases will no longer be with an individual caseworker. Caseworkers will be working through a cloud method, so all of our cases will go into the cloud and pull down as needed per task. We were originally slated to go live February 2026. We have now swapped with Migrant Affairs, and so we will be going on August 2025. So it's definitely a change for us. And so that will be happening then. We also have a contract. We have the ability to partner with entities and agencies that don't use state or federal funds, but other either county millage dollars or corporate agency dollars to have workers stationed at different locations, which will probably be even more beneficial when we go UCL, that people will be able to work specifically with individual clients. We have those DFAs, one actually with CMH and one with the ISD. We did have one with what's called the Employer Resource Network that was working in businesses. However, that contract is slated to end on January 8th. So we had a list, I think it's 10 businesses that we were working with, and so that will be ending shortly. On the child welfare side, obviously, thank you very much for your participation in Adoption Day. We have been doing that and collaborating with the county for many, many years. But I thought it would be good to maybe highlight some kids that we have that we would love to see adopted. So we have 85 kids in care and 9 of them are eligible for adoption. Half of those kiddos do not have an identified family, and we would love to have families identified for them to maintain in Ottawa County. I have 3 that I wanted to highlight that are currently on MARE, which is the Michigan Adoption Resource Exchange. It's a public website for any child that is eligible for adoption, does not have an identified family, and is looking for one. So I just thought I would highlight 3 of our young men. So first we have a male who's 14. He is looking for a family. He loves basketball, enjoys swimming, football, playing outside, going for bike rides, plays video games, watching movies, and spending times with friends and family. He was actually featured on the Michigan Heart Gallery theatrical version, so you can actually look that up online, and he is at the 17-minute mark. So if you're looking specifically for him, that is something that's out in the public, so we would love to see him find his forever home. We also have a male who's 15. Both of these individuals could move as soon as a home is identified. He is extremely entertaining, has an amazing sense of humor, wants to be an engineer when he grows up. He loves sports, especially football and basketball, spending time outside, watching TV and playing with friends. He also is located on the public website, is also featured on Fox 17 under Forever Home 15-year-old. Would love to see him find his placement as well. And then last, we have a 13-year-old male who also is looking for placement. He loves Pokemon, building Legos, playing video games, board games, playing outside, riding his bike, and going swimming. He is also on the MARE website and has not been featured at this point in time, but is looking for a placement in the future. We have a couple other individuals that I also wanted to highlight. They are not listed on any public sites, either A, because they have not said they want to be adopted, or they're still a temporary court ward. Those we have a female, a 16-year-old who's ready for placement. She gets A's and B's in school and is looking for someone who is helping her to transition into independent living. So we are even looking for someone that doesn't want to necessarily be licensed, but be willing to rent a room to her in order for her to maintain in Ottawa County. We also have a male who's 15, could also use placement right now, enjoys video games and loves music, looking for someone to allow him to live in their home as well. And then lastly, a male who's 13, also looking for placement now, would love to find someone who enjoys baking with him. He's extremely smart, enjoys talking and being around others and learning from people. If you are interested in any of those individuals, we have a couple ways that you can express interest. First, by calling our office, 616-394-7242 for our licensing staff, or emailing us at mdhhs-ottawa-licensing@michigan.gov. We would love to be flooded with lots of interest for our young people. And then just lastly, I wanted to do a quick shout out. Every year we provide Christmas gifts to our kiddos. And we have had an amazing corporate sponsor for almost 30 years. Trendway, now Fellows, has taken on all of our kids for all those years. And this year was their last year. So we'd like to thank them for their many, many years of probably thousands of gifts. This year they gave 35 gifts, as we luckily have less kids in care, but would love to partner with another agency or individuals that have that in their heart to give Christmas gifts to foster youth. So if you're interested in doing that in the future, Kristen Korstange is our community resource coordinator, and her email is korstangec@michigan.gov.
Hey, do you have any questions? I am curious about your kids who need to be adopted. So I know you just provided, some examples for outreach or whatever. Is the county helping you at all in forwarding like any videos or anything like that? Is there anything more that we could be doing to help get the word out?
Sure.
Okay,
We would love that. Yeah, especially because like I said, a handful of those already have public, facing videos and such. So yeah, that would be great if we could
Okay.
partner to do that.
all right, maybe I'll email you about that. I used to actually work on mayor placements in Kent.
Awesome.
So I remember, we would have things in the press and stuff like that. So is that still happening? I mean, do you do that with the Ottawa kids or not really?
So each one of them has an adoption worker through different
Mhm.
agencies. They also have an ARC worker, adoption resource worker as well, that's putting them and keeping them on MARE. And then the other things are those partnerships with like Fox 17
Yep.
and some of those entities are the ones that are doing the majority of it. But we don't have anything specific with the county to say like if they were putting a newsletter or
Yep.
anything like that. We don't have that right now. But that'll
Okay.
be great.
Yeah, because it seems like especially if the work is being done with Fox 17, we could find ways to go ahead and push that out. That'd be great.
Yep.
So, okay. All right. Any other questions? No, we're good. All right. Thank
Merry
you,
Christmas.
Kendra.
Happy New Year.
Yep, you
Christmas.
too. Okay, so we are at the end of our committee report. So this is our second opportunity for public comment. If you wish to speak, please come to the podium, state your name, and you have 3 minutes to speak to the board. Would anyone like to make a public comment? All right, seeing none, I'm going to move on, and I just want to share a couple things today. I just want to thank those of you who have come and spoken with us for caring for the people of Ottawa County. I appreciate the work of each one of you and your work for the people of Ottawa, as well as for the members of this HHS committee. While we may not always agree on everything, I appreciate the passion and care that each of you bring to your work. So as we close out this calendar year, I'm excited for the fresh eyes coming to HHS on a national level with Robert F. Kennedy Jr.'s work and the hope he brings for new ideas to improve the health of our children and our nation. America's children continue to experience a rise in autism, ADHD, anxiety, and depression, and suicide and substance abuse continue to plague our nation. These increases can have a direct impact on Ottawa County government obligations, as evidenced by the CMH deficits that we're experiencing this year. As childhood disease increases and mental health declines, America very much needs fresh ideas, which includes starting with the basics of good nutrition and healthy food sources, and getting to the root causes of harm. We must solve these problems. The corporate capture of our federal agencies and the advisory organizations which influence the health of our people from the national to the local level needs to be examined. So I am thankful for leaders who are committed to advocating for the American people instead of big business and big government, and to restoring integrity to scientific research and government agencies. I'm hopeful RFK Jr. and his team will work towards the end of corporate capture of federal agencies and for the positive changes that may bring to the health of children and individuals on the local level. So as we enter 2025, thank you again for your work, and I look forward to a renewed national focus on making America healthy. And with that, we're adjourned. Thank you.
Our talent and recruitment meeting in about 10 minutes.